So good morning and welcome again. This is the second day of this very interesting course on prostatic enucleation. Together with my co-chair, Dr. Thanasis Bekos, I would like to tell you about the program today. We have 4 very nice cases that will be done by our international experts. So today is the day of action, and I think that we are ready to move to the operating room where Professor Fernando Sanchez Gomez is going to do the first HOLEP case. So the mic is on you, Fernando, and please tell us some words about the case. Good morning.
Okay. So as I gather, this is a healthy man. He has some cardiac arrhythmia, but otherwise healthy, who has a 110 gram prostate. So we're going to start. His meatus was a little tight. It dilated very nicely up to 20. So I will do a small otis to make sure that we don't force the entry. Just very mild otis at the, that's it, to enlarge a little bit the caliber of the urethra.
So this is something that you do every time, Fernando?
No, if the urethra is ample, for example, after catheterization, there is no need, and let's see if we can go in. There it is. I'll show you what the otis does. You see the otis does a little cut. You see that? It's very, very little cut, but it gives the urethra some extra caliber, and I think it minimizes the risk of stricture later on. This part of the urethra is a little bit tight too, so I will use the dilator to open up a little bit. Give me the big dilator, the 20 French. It's not a proper stricture, but we need to enter carefully. Let's put it in. Just go in and put it. Okay. So just to be mild, to be careful, and start. Yeah, it went through. Here, there's no problem, and down here, we find this little area here that is a little bit more tight. Let me focus the camera. Are you seeing the endoscopic view?
We have a very good endoscopic view, yes.
You have it, no? So I'm going to very carefully try to go in as atraumatic as I can. It's not too bad. I think it's elastic, but there we are, going in. Now close to the verumontanum. You can see here the veru and
Yes.
the prostate. There's a bubble inside, I think. Let's see if we can get rid of the bubble. It's funny, this bubble, huh? It's okay. Good. So again, there we are. So this is the urethral orifice on one side, and the other side, on the distal face of the bar, and the bladder looks a little bit trabeculated, but nothing special about it. You can see it's a relatively large gland, verumontanum, and as we go out, we're going to see the edge of the sphincter here, huh? Let me focus a little bit better. Let's get the fiber, please. Fiber. The tip of the fiber for me. Beautiful. Thank you. So let's start. We are using Richard Wolf instruments, which are my favorite for HOLEP, and we are using the Moses laser system, Holmium 120 watts. Is it ready? Okay, and so I will start by marking, you see, the limit of the sphincter with the apex. As we said yesterday, this maneuver, or just setting up the white line, is a good way to protect the sphincter's mucosa. So I'm going to come up here. We can check again. You see, this is the edge of the sphincter, so we are right at the limit. Here, you shouldn't be shy because it's very, very safe. There won't be any problem with continence. And it's always a pleasure to use Moses because it has enhanced a lot what holmium laser can do, in the sense that we get excellent dissection, and we get excellent hemostasis at the same time. Here I am entering the plane between the adenoma and the capsule, right? Just following. You can do a little bit of mechanical dissection as well, very gentle to find that you are in the right plane, but I'm quite happy there. So here again, we go to the other side. I like to cut these little fibers here because when we enter this space with the resectoscope later, it's nice if you don't force anything. If you just, cut the mucosa, prepare the entry. So here we will let the laser do its work, both dissecting and coagulating. Here, that looks like a good plane there. So just very gently and very carefully, we are entering the plane, the posterior plane, okay? So if we look back now, we will see that we enter the plane in both sides. Look at the sphincter, it's okay, And now we will cut above the verru through the frenulum to try to connect both planes posteriorly. This area, it's a little bit fibrous, and I'd rather not do mechanical dissection, but I prefer to do this cutting. So now you see we have the line of dissection. It's a line that we can follow posteriorly, and what you have to do with HOLEP is to position yourself properly. And you see the position of the scope is going to be aligned with the line of dissection. You see, this is my line of dissection. The scope is looking at the line, and you can see anteriorly a little bit of adenoma and posteriorly a little bit of capsule, all right? So this is the way to
Fernando?
Yes?
Is it possible, I mean, for the technical team to have both the endoscopic and the image from outside to see your movements?
Can you do a view from outside to show my hands or to show what I'm doing? Okay, they will try. So basically, you see what we do is we get close with the camera to the line, and you see that by getting close, I'm opening the space a little bit. I'm not pushing. I don't want to dissect pushing. I just want to position myself so that we can see the plane, you see? And the fact that the endoscope is almost touching with that region is going to help with the dissection a little bit, because it generates a little bit tension and counter tension, you see? And then when you fire the laser in the middle, you will get some dissection. Here, there's not so much tissue. Here, this is the entry to the urethra. Let's see if we can open up a little bit more. So very gently and very carefully, we're going to progress to dissect the line. I think it's important to reflect about what we said yesterday. We have the settings of 2 joules and 50 hertz with Moses setting. So, Moses has a double pulse that will, the initial pulse would mainly open the plane, and the second pulse will travel through the initial bubble and will reach a little bit further. So what we have gotten with Moses and pulse modulation is a much better hemostasis as we go. You see, this is what I call first pass hemostasis. So when you dissect the plane, you get excellent hemostasis of the plane. Then, of course, you have to be aware that the energy settings is not the only determinant of tissue effect. All right. So the distance is important. If I fire too far away from the tissue, nothing happens, because the holmium light energy, it's going to be absorbed by the water. So if you get a little closer, you see you can get this mix of dissection and hemostasis at the same time, which is the ideal one. If you get too close to the tissue, you might make a little hole. So, you have to control the distance. Okay. Now I'm going to put my fiber at 12 o'clock. You can see up here we have the edge of the sphincter. So you see we have to liberate the apex. And I have to start by cutting a little bit deeper into the white line. Let me see if I can focus at a better proximity here, like that. So you see we have to enter this plane down there. But when you do a little bit of deepening of the cut, like that, even cutting on the adenoma a little bit, you will get much better access. So I don't mind cutting here on the adenoma a little bit. But of course, I want to look for the proper plane. So here we're going to try to enter the lateral plane. So I'm going to go and enter the lateral plane if I can. And initially, I will just want to gain 2 or 3 millimeters upwards, you see, like this. But I'm going to take the dissection progressively towards the bladder neck. You see here, deepening a little bit my dissection. And also, this is what I call mobilization of the apex and connect. I want to connect the lines. You see, we had a line posteriorly, and I want to connect the line posteriorly to the line that we are doing laterally. Okay. And here you will notice how we are starting to see a little bit thin capsule. So then, of course, not only the speed of movement is important, but also where you aim your laser. So I'm going to aim a little bit closer to the adenoma so that we don't deepen in the capsule, okay? But now this apex is mobilized a little bit laterally. You see now we have a much better entrance to the lateral plane. But before I continue going up, I don't want to be, you see, inside here dissecting upwards, while the scope is making traction here, you see? I don't want to put traction on the apex. So what I'm going to do is to open the apex first. You see a little bit? I'm cutting on the white region. So I know the mucosa is going to be perfectly okay. And when we have better access, you see, when we have better access, we can go now a little bit further with our dissection, following the plane that we already started, and taking it a little bit more up. But again, I will deepen. I will go towards the bladder neck because I need to mobilize the apex. Mobilize the apex. You see, we want mobilization of the apex to be able to reach the anterior parts without putting too much tension in the sphincter. Regarding the plane, you see, sometimes we see a very beautiful plane. Sometimes we don't see it. But we know how to recognize the plane. You see here, we have a surface that is fibrous, you see, mostly white. We don't see a lot of yellow elements there. The adenoma is going to be more yellow. Maybe I need the table up a little bit. Table up. Raise the table, please. So here you see at the apex level, we are coming towards 12 o'clock area here. This is the 12 o'clock area. A little bit. Okay. Thank you. 12 o'clock area here. We were able to mark our white line here, but we didn't finish all the way towards 12 o'clock. But now, you see, we just have to continue with our dissection anteriorly towards the 12 o'clock 12 o'clock mark here. Brilliant. So now we continue coming up. You can see, for example, this is adenoma. You see, it's yellow. It's yellow. So we have to go out because we want to take all the adenoma out. So we have to explore a little bit further out because we want to reach the anterior-most part of the capsule. Sometimes we play in a very thin, you see, very thin capsules. When you see these big prostates, many times the peripheral zone gets very thin. So we have to be careful, but at the same time, we don't want to play it excessively safe to that, so that we leave adenomatous tissue. All right. Now look at the beautiful line. Yesterday, I showed you the MRI image of a prostate, and you see the line that goes around the adenoma. You can follow it very nicely. It's very uniform usually. So even when we don't see the plane characteristics, when we don't see the beautiful plane, which, you know, not always we can see, we know that we are in the good plane and it's everything is uniform. And if we want to connect with the posterior plane, you see we have this initial line here. So if we want to connect, we can connect. So we don't lose ourselves inside here. Okay, it's just a very simple, the mechanism of an orange. We are just dissecting the orange. But now we have to come to the apex and release this side. So here I think we're going through the right plane here, anteriorly, right plane, anteriorly. Here we are. And it's also important to start developing the anterior line. You see, we did the lateral line. Now the direction of the plane is changing. And if we are able to go a little bit, let's say, on top of the adenoma with the scope, you see, this will make the apex descend. The apex will fall down a little bit on this side. That we are looking now at a little bit easier plane to recognize, I think, up there. It looks good, a little bit. You know, you shouldn't be afraid to see these little aspects, little things, little fibers crossing from side to side. Don't lose track of the line. You see, the line is telling me this is the good direction here. And you see, this is anterior aspect now. Let me focus a little bit better if we can. Here. So you see that with this laser, we don't need to do a lot of hemostasis as we go. This is the 12 o'clock region here, you see. And now we're going to come to the other lobe. This is the other lobe. This is the edge of the sphincter here. You see how the mucosa of the sphincter easily breaks if you're not careful. And if you continue with the dissection, what happens is you detach the mucosa from the sphincter, and then you will have this curtain. So I'm going to avoid the curtain. I'm going to go a little bit here, deepen in the adenoma, into the adenoma, a little bit so we can get access. Initially, I don't mind cutting here because I'm going to go to the good plane. Look, the cut is here, you see? It allows me to individualize the sphincter from the apex of the prostate a little bit, and then we can go to the good plane. And here again, I'm going to repeat what I did on the other side. 2-3 millimeters up, going up and down like this to try to mobilize and connect the plane with the dissection plane we had before. Let's see here where we are. This is looking good, but this is adenoma. You see here we have to go around this adenoma, I think. Carefully.
Dr. Sanchez, how important it is to have absolutely
It's
the
like
right
a nodule
plane?
there that we want to remove if we can. So again, let's try to be systematic. Systematic is good. So here I am trying to go from the posterior plane to the lateral plane. Let's continue. You see, I saw that nodule going into the capsule, and I think you have to follow these nodules. All the yellow tissue like that, you see, this is normally, this is adenoma, huh? But here the capsule looks a little bit thin, so we have to be careful. Probably, yeah. That's slightly deep. Let's see. Yeah, we have to find out. Sometimes we find out as we go. So here, let's try to come up some more millimeters. It's difficult to keep the focus always okay, because sometimes we are a little bit close to the tissue. Sometimes we separate, and at this distance, I think it's not so easy to keep the focus right all the time. But here, what I'm trying is to continue this dissection at the bottom here, mobilize the apex and connect with the line that we had before. Here, you see, this is connected now. Let's see if I can focus at this distance so we can see more detail. This is looking good. This is yellow, huh? This yellow stuff is usually adenoma. So very slowly we have to, I mean, in the philosophy of HOLEP, if you try to make sure that every minute you move forward, you do something that makes the case better, then sometimes we're going to be very, very fast with the procedure. Huh? So here, so far, I think so good. We want to remove all the yellow stuff, but at the same time, we want to keep inside the prostate. Huh? We don't want to do a bad perforation. And the way to keep in the plane is to be very sensitive to where you're aiming. Huh? The aiming is very important. So here, we're also coming up. We are connecting this line with the posterior line here, you see. We can follow this line, and that will help us orient ourselves really well. Everything we see in the plane is fibrous. You know, it looks like capsule. And here we're coming up. You see towards 12 o'clock on the apex. Here we are. This is apical tissue here. This is what we marked. So we are doing well. We want to come up here and release the apex before we continue our dissection. Yeah, this is good. This is 12 o'clock region. And now we continue our dissection upwards, trying to go from the lateral plane now to the anterior plane.
So, Fernando?
Yes, go ahead.
So, if you had a big middle lobe, would you change your approach, or this unblock technique is fits for every prostate?
Yes, you can do unblock in any prostate. We don't care about middle lobes. You see, I think the middle lobe is a problem when you do the 3-lobe technique, in the sense that sometimes big middle lobes, demand to do very big incisions. Here, we don't care about middle lobes. This technique is particularly good, when you have to do a redo case. Yesterday, we saw a video from, I think it was Vincent, showing a prostate after TORP or something like that. And sometimes you cannot even go in the bladder, So if you start your dissection at the apex, you don't need to go in the bladder at the beginning. You can just start and go. Huh? So middle lobe is not a problem. So here you see everything is starting to look much better. This is the direction of the plane going anterior. But as I told you, I don't want to force things here. So I will come out, you see, to see where we are, and to make sure that we cut the tissue in the white region. Here, this is white. Let's cut here, so we don't force the entry to the apex. Huh? This is a horizontal incision below the sphincter, so we are quite safe. The thing is, when you see HOLEP one time, You might be lucky and see a very beautiful case where everything is clear and everything goes really well. And then you have the impression that HOLEP is a piece of cake. And then when you see a very difficult case, then you might, have the impression that it's a very difficult operation. But, the truth is in between. Sometimes we see very easy cases, very easy planes. Sometimes we see somewhat difficult cases. So at the end, that's why I recommend people to see many cases, because when you see many cases, you will understand the basics of this procedure. Let's see what we have here. Here we have the other side. Maybe some vessel was bleeding, so I will clear the field a little bit, because when you fire the holmium, these bubbles and this mechanical effect of the holmium will clean up the. This is the urethra. Let me see where we are. This is belonging to the sphincter here. So the 12 o'clock approach sometimes is a little bit tricky. Let's see if we can connect anteriorly. The idea of this approach is that when you have a nice, let me see if I can show you. When you have a nice understanding where is the plane going up here, you see, we can approach let's say the 12 o'clock area carefully from both sides. Sometimes I manage to show it beautifully, sometimes it's not so easy. This is all anterior plane. You see here, there is some attachment anteriorly. So it's a white attachment, so probably we should be cutting through it like that. Let me see. There we are. Sometimes this 12 o'clock region is a little bit tricky. Here's the other side. You see here, we're coming towards the other side. So you just have to connect one side with the other side, go like this. Try to cut the most distal aspect first. And we're nearly connected anteriorly. I don't know if I can show you better. Here we are, coming up. This is a 12 o'clock attachment. And now we should be able to cut this little bit of tissue here. And then I think we would be connected anteriorly. This is the end of the, let's say, early apical liberation. What I have tried is to go around the adenoma, and to approach the 12 o'clock area very carefully. Here, you see now we are able to connect one side with the other side. And now, from this moment forward, the sphincter is totally released. It's totally free from traction. It will close around the endoscope, and it will accompany the endoscope on its movements, but it's not being distended or anything. And now we enter in this phase that I say it's easier, because you see we have a line around the adenoma. You could imagine the orange. We are peeling the orange. This is the line that we see on the MRI. It's very uniform. And we can follow this line all the way, because we were careful to connect the lines. You see the posterior line connected to the lateral line. The lateral line connects to the anterior line. And then we just have to go around. Let the holmium do its work of looking for the plane, you see. Try to aim your laser. We saw 4 determinants of laser effect on the tissue. The first determinant is the settings of the machine. The second determinant is the distance at which you fire. It's not, if I fire too far, nothing happens. If I get closer, you start seeing the effect. So you have to check. It's sometimes it's very subtle, just less than a millimeter difference. So you want to achieve an effect that will give you some dissection. But you see, if you fire against a tissue like that and there's no movement, there's no dissection. So you have to combine the right distance with the movement. And then you can move very slowly like this, or you can move faster. You could go even much faster sometimes. So what you have to start understanding and what you have to do when you do HOLEP is to start trying a little bit. Let's try this distance, let's try the speed, and see how it goes. I would say probably the ideal speed of movement is that movement that gives you good dissection, but at the same time gives you good hemostasis, okay? And then, of course, it's the aiming, you know. If this is our line, let me show you the line of dissection. This is the line of dissection here. If I fire outside of the line, I'm going to go in the capsule, you see? That's not good. If I fire against the line, sometimes, especially at the beginning of the procedure, it's going to be okay. But when the planes start changing direction, you know, this would be against the capsule, in the line, and you have to get closer to the tissue. You have to get closer because you want the energy to disrupt the fibers that hold the capsule and the adenoma together, but you don't want to deepen in the capsule. Huh? So here we are coming now towards the bladder. Huh? You can see as we dissect anteriorly, you start seeing this pattern of circular fibers here. You see circular fibers of the bladder neck and vertical fibers here. So when you fire here, you enter the bladder, okay? So the vertical fibers under the circular fibers is a very pathognomonic sign that you are entering the bladder. So here you see, here we are now cutting the bladder neck, So, you know, it's funny that the anterior commissure is here below me. And if you could see the outside, you see that I have at 12 o'clock, but I'm not pushing my scope down. You know, when you have to do a 3-lobe HOLEP, in order to reach the 12 o'clock, you have to push your scope down and angulate the scope a lot. Here, what's happening is the adenoma has been mobilized. You know, now it moves, and it is compressed by my scope. So I don't need to force too much. So in this technique, instead of taking the scope to places, what you do is you mobilize the prostate so it is not so difficult to get to those places. Look, this is the beautiful plane. Sometimes we see, you see, the beautiful plane. Of course, with this kind of energy, sometimes when you coagulate the tissues, you realize that the beauty of this plane is no longer visible. You see, every time I fire, it's getting coagulated. That's why you cannot base your enucleation in watching this plane, because you're going to be spoiling the plane all the time. So you have to recognize the plane by other factors, you know, like the fibrosity of the plane, the smoothness of the plane, the many ways to know that we are in the good plane. Huh? And also, I would say that the color is important. As I said to you before, the capsule is more white and the adenoma is more yellow. So that gives you sometimes, you see, yellow, white. Huh? So it's very subtle, but it helps a lot. And here what I'm doing is I'm following my line of dissection here. You see, we have the posterior line of dissection here, and it has to connect. If you can picture the MRI image in this region here below the adenoma, when it turns from the posterior plane towards the lateral plane, this is probably the wider area. And sometimes going from here to up is a little bit tricky because the angle is quite steep. So here you see how my fiber is now very close to the adenoma. I don't want the energy to perforate the capsule when the angles are changing and there's a very thin plane. This is yellow. You see, it looks like an adenomatous nodule, you see? So I have to detach it from the posterior capsule that looks a little bit thin. So carefully, but we will try to take it out if we can. That looks somewhat yellow as well. Let's see. You see, this is a very, very thin plane down there. But we try to take all the yellow with us. Huh? Good, so let's come now up here. This is bladder neck region. You see here we have to go in the bladder and check the position of the UO. So we are quite far. It's looking good. And many times when we have these sides already done, the only attachment remaining is the 6 o'clock attachment. You see here I can cut the mucosa of the trigon a little bit. So in this side we have a nice bladder neck. If we go to the other side, let's see how it's looking. Maybe we didn't cut too much here. So this is bladder neck. We have to go down also. Bladder neck. You see, that's looking good. And here at this level, I would go in again to check the UO. It's quite far, so you see now we have the adenoma almost hanging from the 6 o'clock region. The case is nearly finished, but this is sometimes a tricky part. So because of course when we do en bloc, we have many advantages. You have seen the excellent irrigation all the time. We could see perfectly all the time. The excellent orientation, we don't have, we're going from the apex to the bladder neck. We are pursuing always a forward, dissection. We don't have to go back, check the incision, detect landmarks. So it's much more simple concept than the 3-lobe technique. And but of course, there are some disadvantages, and sometimes the end, this posterior dissection is a little bit tricky. You have to start gaining millimeters. 1 millimeter more of dissection will help you a lot because it will facilitate moving forward. So here we want to be careful, especially the capsule here is very thin. So we have to go from side to side. You see, gain a little bit more dissection, 1 millimeter more, 2 millimeters more, will mobilize the adenoma even further, and then we will be able to continue. This is what I thought could be a little bit of adenoma. In these difficult parts, when you see adenoma in a very thin capsule, you can also use the vaporization effect of the laser to take that tissue out or to destroy that tissue. But here, we are almost done. Now, this is an attachment. Let's try to cross towards the other side very carefully, aiming the laser towards the side of the adenoma. We don't want to perforate in the capsule. And here, let's see where we are here. You see, it's a very little by little dissection at the end, and I think this is almost mobilized completely. Okay, so one thing we can try is to get under, you see the right lobe, you lift the adenoma, and then you push the adenoma. So one of the lobes, you see, this is the prostatic urethra, this is the bladder neck, and this is the lobe already trying to go in the bladder, you see? So when you flip the adenoma like that, what happens is that this side opens even more, so we can reach much better here to finish, you see? So now we will finish this final attachment. We will finish this final attachment. We have much better access now to check how it's looking. Look at how smoothly the energy can be used. If you separate the fiber a little bit, you can reach a moment where there is a very mild cutting or dissecting effect, very good hemostasis, but it's not disruptive. So here you see, now we can see the last 6 o'clock attachment here. Now everything is nearly released. So I think we will finish with this. This is now the last attachment at 6 o'clock, and the enucleation is finished. So in order to push, there's a vessel somewhere. Let's get some hemostasis while the adenoma is still. This is too thin, too small. I have used a setting of 1 joule and 30 with a long pulse for hemostasis. It works really well. It's a little bit slow. Let's see. Sometimes it's just one vessel going. You see, the quality of hemostasis is quite good. after the first pass. No, maybe there is some vessel that we can check in a moment.
Fernando?
Yes, go ahead.
So you made it look very easy, but I don't know if this is the case, because it was a very impressive demonstration of the enucleation. And also we are very impressed by the clean incision, so we don't have any charring.
Yes, holmium doesn't produce charring. Well, it's more like not an effect that is for the holmium. It's the pulsed lasers. Pulsed lasers deliver energy, but then when the pulse stops, there's some relaxation of the temperature, and so they don't heat so much. But there was a question in the operating room. What was the question? For coagulation.
Yes. Also for our online participants, Bill,
They are
please,
asking me here.
yes, please feel free to send your questions. Go ahead, Fernando.
Yeah, there is. Let me answer the question that they made here. They're telling me if I use the same set or different settings depending on if I have to coagulate an artery or a vein, and really, no, you have to try. Sometimes you're very lucky with coagulation. One of the aspects that you see, the fiber doesn't degrade a lot with Moses. This is a big advantage because the profile of the beam is very good. Sometimes when you work with a classic holmium, you find that the laser doesn't coagulate well, no, and you think, what's going on, no? And the thing is that the beam is a little bit damaged, and it's not coagulating properly because the fiber is very degraded. So when the light comes, instead of emitting a proper beam, it emits a very, very bad, beam, and the coagulation effect is altered. So I try to coagulate, initially probably if my pedal is in the let's say dissection setting like now, you see you can also coagulate with that. The only thing you have to do is to separate yourself a little bit more from the tissue. But when you are coagulating in a very thin capsule, sometimes if you get a little bit close, you see it could be disruptive. So if it makes you a little bit afraid of using the high power at bigger distance, you can just switch the pedal and then you get a much smoother effect. You see, it's coagulating, but it's not so aggressive with the tissue. Okay, so now we're going to flip the adenoma into the bladder completely. We will check the hemostasis later as well, but instead of pushing this side towards the left of the screen, I'm going to push it also towards the right, you see? And you see how easily it goes into the bladder. Many people think that with en bloc, you cannot push the adenoma in the bladder when it's big, but it's a matter of rotating the adenoma, no? So now I'm going to spend some minutes doing hemostasis until we have a very, very good view. Let's check again. This mucosa broke a little bit, but the UO should be perfectly okay somewhere here. Let's see. This is the one. And this is the other one. Here there was some mucosal detachment that could cause a little bit of bleeding during morcellation. So we have to check not only the fossa, but also the mucosal edge, because one of the bad things of holmium is that when it cuts the mucosa, it's a very explosive cut. And that's the mucosa doesn't like it very much, and it tends to bleed a little bit. Often we leave open vessels like that. So one of the things that can give you a hard time during morcellation is that you didn't coagulate the mucosal vessels, and then you don't see. So yeah, we have to check. There's a bleeder here, you see. Sometimes you have to spend some minutes. Of course, what we saw with Moses is that the time we spend doing coagulation is much less than before, because the initial coagulation is more effective. No, let's see. We have some apical bleeder here that is causing most of the trouble, I think. So I don't know how long it took to do the enucleation. Of course, it's a didactic case, and usually with didactic cases, we go a little bit slower. But for many people, holmium laser enucleation is a very, very difficult technique. It's a very long technique. So many people think that this takes hours to perform. Many people have the idea that holmium laser is an operation that can suddenly go very bad because you can have a problem, you can have a perforation, you can have a morcellation accident. And the truth is that it's no longer taking so long because of the good hemostatic properties of the new lasers, the better and the technique. Also, I think en bloc is faster than three-lobe techniques usually. And also, it's a very technical technique. So instead of being anxious when you do your HOLEPs, you have to be very calm and very relaxed and just tackle the problems you find technically. We are starting to see better. Let's come out and see what's going on here. This is the sphincteric area. There's a little bit of a nick here in the mucosa, but because of the traction. But I think the edge of the sphincter is here, so it's going to be fine. I'm sure it's going to be fine. We don't see almost ever stress incontinence after this procedure. Sometimes, the dissection movements and produce a little bit of ischemia in the region. But the fact that we mark this initial white line protects the sphincter function really, really well. And it's not the same, when you have a longitudinal nick in the mucosa, when the sphincter closes, this is the ejaculatory ducts, you see? Ejaculatory ducts. So that's why we will see that he has a retrograde ejaculation. And then I think we're almost ready to go to
So, talking about ejaculation, how easy is to preserve ejaculation with these preserving techniques?
Well, I think for ejaculation preservation with holmium in the big glands is not easy, and it's not very predictable. You can try. Often you can get a good result on a patient who tells you he can ejaculate, but often you can't. There is a paper out from a group doing thulium preservation with enucleation, THULEP plus preservation of ejaculation, and they allow to have 87% of ejaculation preservation. What they have to do is they have to protect the veru region, so they leave apical tissue here, and they are very careful to try to preserve the ejaculatory ducts and some of the paramontanal tissue, to preserve. But it's not very predictable, I would say, in the very large glands. I think we have much better chances of preserving ejaculation when you do smaller glands. So, but I think probably thulium, the cutting of thulium is much more consistent than the cutting of holmium. So if you want to, let's say, make a decision of what you're going to take out and what you're going to let in the prostate, when you have that idea of what you want to preserve, the thulium laser allows you much better to do. So I wouldn't be surprised if we start to see papers of thulium guys achieving good preservation rather than holmium guys, because this explosive nature is very good to dissect the plane when you are in the plane, but it's not so good to cut the adenoma in the middle, So here we are. I think we have good hemostasis. Now we're going to move on to the morcellation. So the fiber is for you. You can now give me this instrument and I will change it here. Can you dry this with a gauze first? Just in case there's some water. Just dry around and inside. Okay. Beautiful. Now help me like that. Beautiful. Pull hard. You need to pull hard like that. Beautiful. Now I will connect the light. get the morcellator ready. Let me just, the plastic is in the middle. Okay. Now, I'll take the water. Let me do it for you. I will release this and you just have to remove it. Okay. So now I'm changing the instrument. Here's the morcellator pedal. This is the morcellator going in. Now, to morcellate, I'm going to position myself here in the bladder neck, you see. I'll go under the piece and lift the tip and lower my hands, okay? It seems to be morcellating okay. So the idea of morcellation is, many people are very afraid to use the morcellator. So what they tend to do is they tend to keep it like this, very close to the lens, because this way they think it's less dangerous. But you see that most of the screen is covered by the adenoma. So if you put the blade a little bit inside like that, what you get is, of course, the adenoma above, you see, the morcellator blade below, and in both sides of the morcellator, there's a black triangle. And this black triangle is your safety, let's say, check. If we go closer to the bladder, you see the black triangle at some moment is going to show us that it's getting more pink or more white. Huh? So if you see this pitch black color around the blades, we are okay. We are far away from the bladder wall. You see, most enucleators use 2 inflow sets, with 4 bags to morcellate, because, of course, they think if you put more water in, there is less chances of accidents and so on. You know that all the outflow of water in this moment is happening from the tip of the morcellator. So all the outflows are closed, and it's only the tip by the effect of this aspiration that is taking out water. Okay, but I love simplicity, and I think that HOLEP is probably too complicated already, in the sense that if you have to put a second set, more bags, change more bags, it becomes a little bit cumbersome, difficult, or So I use only 1 set. But of course, I am very careful to observe the efficiency of morcellation, because I have observed that when you morcellate the tissue, and if you look at the blade, you see that most of the time the blade is covered with tissue. You see the mouth of the morcellator is covered with tissue. That means that the tissue is constantly blocking the outflow of water, you see. So you are sucking water out, of course, but not too much. So here you see it wants to go from one lobe to the other lobe. So what I mean is, if you have efficient morcellation, usually the bladder will remain full. But if the morcellation is not very efficient, like when it gets at the end, sometimes we get these nodules, the beach balls, and then you see the blade rotate like this, sucking water all the time. This, of course, you have to stop that, because that will empty the bladder very fast. So it's a balance. You have to check the balance. You have the possibility of palpating the bladder to see if it's full. In this case, it's very full. So simplicity is good, and it makes the procedure faster, easier, less cumbersome.
Dr. Sanchez,
Yes.
do you have, in the cases that there are a lot of stones, do you have any special precautions when you morcellate?
Yeah, well, stones can damage the morcellator blades a little bit, and they can block the motor, So sometimes when we have to do prostates with lithiasis prostatitis, that where the stones are included in the tissue, sometimes it's a problem for morcellation. It's not very common, Of course, when you do big stones before enucleation, you have to clear the bladder so there are not too many remaining stones fragments, because this could damage the morcellator. The Piranha has really led the new generation of fast morcellators, and it's a joy because you can take out around 10 grams per minute. So if this adenoma is, I don't know, 90, 100 grams, 80, something like that, it should take only a little bit, only some minutes. It's getting full? No. So also morcellation has cut down the times a lot, and to me is the major paradigm changer, because before, I think, to morcellate an antigram prostate would take 1 hour and a half or something, so 1 hour. So it was a tough enucleation, and then it was a tough morcellation. Now, with these new lasers that have these excellent hemostatic properties, there's a second generation of holmiums, the pulse-modulated holmiums like MOSES and the Quanta Virtual Basket. And there is a second generation of thuliums that would include the pulsed thulium lasers and the TFL, the thulium fiber laser. These thuliums have much lower peak power than holmium, and that means that when the pulse is emitted, there is less peak energy, and that is what produces the bubble and the mechanical dissection effect. Okay, let's wait until it doesn't. Okay, let's change. So stop. Yeah, take it out. Maybe you can also take out the tissue from the basket if you want. We are changing the buckets. This is one of the problems with. So where was I? Okay, so as I said, holmium lasers have a high peak power. High peak power produces a blast that will dissect the plane mechanically. So that's why I just point the laser towards the line, and the holmium laser is going to open the plane following the path of least resistance, which is the interface between adenoma and capsule. But when we use thulium lasers and the thulium fiber, what happens is the peak power is not so big. So you have less dissection effect and a more cutting effect. So I tend to think of the pulses from holmium like a little scissor opening, So you're opening the scissor around the plane. And I tend to think of the thulium lasers as a surgical knife, as a very, we don't have water. Very, how do you say that? Sharp edge knife. So with thulium, you can easily lose the plane, whereas with holmium, you can keep in the plane much easier. But the second generation thulium lasers offer an excellent hemostasis. You see, often when we have reduced the adenoma, we can start bringing it to the fossa, you see? So you can do morcellation inside the fossa. And often it's a good idea because the morcellator preferentially eats the tissue that is softer, and nodular hyperplasia of the prostate, some of the nodules are quite fibrotic. So there's not the component of glands in the nodule is not so big, and it's more like a fibroma. So the tendency is that the morcellator will eat the soft tissue first, and then it will try to go and eat the tougher tissue, which is left for the end. So often when that happens, the morcellator has trouble chewing this harder tissue, and the piece goes away from the morcellator more often. So if you keep everything inside the fossa, you see I'm totally immobile. I'm not moving myself. I know I am in a safe spot, And you see the morcellation is happening very nicely. Of course, the visibility got a little bit worse because there must be some oozing vessel in the fossa. But I think here is fossa. That's the last, I think, remaining piece. Let's see how it goes. It's a big one, eh? It's a big prostate. So I hope you enjoyed. I would push you to try to learn HOLEP. You know, it's an effort and it needs some commitment. You will need to travel and watch. You know, you will need to make an arrangement with people in your country who already do HOLEP so they can help you. But it's really worth it. It becomes a very easy operation when you have done a number of cases. You feel very comfortable. You feel very relaxed, and it's like a superpower. You know, you can handle these men with very large glands. They come to you looking for a solution for their problem, and the next day after the operation, they go home without a catheter, and they can't believe how well they are. You know, and that's almost the end. There's some fragments in the fossa. Let's see. Sometimes clot will form in the fossa because, despite the quality of hemostasis, there is some oozing vessel from the mucosa. Also, the morcellator set does not irrigate properly. You know, there's inflow of water, there's outflow, but there's not very good irrigation. So I think we finished. Now we're coming out, and let's put a catheter. Thank you. Look at the flow. So we finished. Try to learn HOLEP because it's a game changer, and you'll have a lot of happy patients and more patients. It's a lot of fun as well. Everything went really well, I think. Good, so I hope you enjoyed. Is there any questions from the floor?
Actually, thank you very much, Fernando. It was really a very impressive demonstration, and I think that you deserve a big applause from the audience here. And I'm pretty sure that also the online participants would like to congratulate you. So there's a question about, tell us about the low and high power HOLEP, because there is, again, a discussion about that. So what is your personal opinion on that?
So we put 40, no? Yes. Low power. Well, as I told you before, the settings are not so important because the surgeon plays a very important role in the operation. So if you use a low power, you're going to need to do more passes to get a good coagulation and probably a good dissection. So with a high power, the microphone, sorry. With a high power laser, maybe you pass less often, you know. So the fact that the energy coming from the fiber comes with a lower power does have nothing to do with how much energy the tissue is going to receive at the end. And you know, two different surgeons, maybe one with a high power laser and another with a low power laser, will deliver a similar amount of energy to do the dissection, to do the job, and to do the coagulation. So I don't think it is there's any advantage on using low power. I have used low power and I have used high power, and I have to say I prefer high power because high power is faster, hemostasis is easier, and I think you know, it's not a mathematical thing. Low power will give you less dysuria, and high power will give you more. No, just so yeah. I worked with low power, and I suffered a lot to coagulate the big vessels. You know, sometimes you have to face difficult cases. So I would recommend you to use high power. I think this was something that Scofone, let's say, promoted. But I think not anymore.
Well, I would also tell something about low power. That's what we are using actually. And in fact, after the operation, almost always we need to coagulate with monopolar or bipolar, so it's systematic. But and now with high power, you don't need this step, and it's much quicker. And I'm not sure that the irritation symptoms are more with high power than low power.
So, Fernando, please,
Yes,
could you
leave it,
summarize
yeah.
the take-home messages for those who want to start with HOLEP?
Well, definitely, if you don't do HOLEP in your hospital, you need to make a commitment to learn. Watch many videos, go to visit centers of excellence, and you will then discuss it with your manager. Look at the investment you have to do carefully, but yeah, you have to do it nowadays. This is the moment, and I'll tell you, there's an explosion of centers in the world adopting successfully HOLEP. Once they become, let's say, proficient with it, they are absolute enthusiasts, and they promote it all the time, and they brag about it. So, but you shouldn't be crazy like we were in the past. Many centers try to do HOLEP with very little experience, and they had trouble. So learn properly, get a mentor, try to find a scheme so that someone with experience come to help you several times, not just one. And then, of course, you will be able to learn. It's okay. I would wait a little bit. Yeah, it's not so bad. It's irrigating.
A bit of traction, yeah. It's okay.
Yeah, it will settle. Good. So we're moving on to the next case, I think. Morning.
Thank you very much.
Was the
Thank you
dinner
really
yesterday?
very much.
Huh?
It was.
So, Andreas, we are moving to the next case
Yeah.
in
Sorry.
30 minutes. So there is a break now.
There's a break. Brilliant. I think it's fine. No need to traction or anything. Just let it settle down. It was good hemostasis. Just the first 2 minutes, it's a little bit more red, and then it gets better. So I hope he will be okay. Let me get my phone number so you can tell me, or if there's anything that we can discuss, or any trouble you want to discuss.
Do you think there are some more dangerous zones in order of capsule perforation with this technique?
Typically, it's the
Goat?
trigon. The trigon.
Ah, the trigon.
Under the trigon. But very often we go a little bit deep there. There was one area here that is a little bit like that. But you do an ultrasound on this, no problem. There's no extravasation. If there is a little extravasation, it's no problem. The next morning we take the catheter out. They're fine. When you are an experienced TURP surgeon, sometimes you see the capsule, you see deep areas. You don't care. It really doesn't matter. So this is not more dangerous than TURP.
If you recognize it,
It's really, we do 5 cases in one afternoon. So last week I did 300 grams, 200 grams, 140, and then a redo case in the same.
So actually, the idea is to have now a break for 15 minutes, and most probably Dr. Gomez-Sancha will be here to discuss the case, or if you have any other questions. Okay? So I think it's a nice idea to have a break.
Hello, everybody again. I hope that we're trying to get ready for the second case. The surgeon will be Dr. Jose. And we're waiting to be connected with the operating theater.
Je préfère que ce soit direct.
Hello. We're live. Do you hear me?
Yes, we can hear you.
Okay.
I wish you can.
So can you please present the case to us? Whenever you are ready.
Hello, everybody.
Good morning, Jean-Baptiste.
Morning. How are you?
Fine, thank you. And could you present the case?
Yes.
to us? I mean, some baseline characteristics of the patients, and because today we have this is the second case with tulip. So please.
Yes. So it's a 62 years old man who had a previous incision of the bladder neck, as you can see, and he has a recurrence, as always, after that kind of surgery. It's an 80-gram prostate, no complication, and I think he had a stone, a bladder stone before, and he had just a bladder lithotripsy before. And so the first problem we had was a small problem with the urethra, which is a little bit tightened. So I just do light urethrotomy to put the Storz resectoscope, which is a 26 Storz resectoscope. It's quite good because it's very smooth, but the problem is the size. So with that, you're going to have a good irrigation, but the problem is to have a compliant urethra. So I think it's going to be okay. So I do the urethrotomy, and we will try to put the resectoscope inside the urethra. Thank you. Thank you. So let's have a look on that.
So what kind of instruments do you use?
So I use the Storz device. So I don't want to be traumatic with the urethra. It seems to be okay now. Okay. So I'm going to use the resectoscope. So as you can see, I use, as you will see, I use two wings to try to optimize the exposure of the plan. As you can see, if it fits well, okay, like this. So it was something I began when I began my activity and of enucleation, and I kept it. I have to. Just a second. Non, non, il faut que je mette là. I have to connect the resectoscope well. Attends, c'est sur 0. Okay, I think it's going to be okay. Ah. Quelque chose qui déconne. Hein. Il faudrait qu'elle tienne, je sais pas. C'est peut-être la pièce. I just have to adapt the resectoscope. So we change one piece of the Storz system. Is it correct? We will see this in a minute. Yeah, it's better. Definitely. Okay, so let's check the anatomy. So first we're gonna see the verruc, we're gonna see the sphincter, which is quite long for this guy. Okay, I think that as probably Fernando told you, the endoscopic anatomy is very important in this. It's not endoscopic management, it's surgical endoscopic management. Okay, so we have to perfectly see what we have to do. So the sphincter, the upper part is here, and generally the stress urinary incontinence is due to a lesion of this upper part of the sphincter. As you can see, we see the verimontanum. Perhaps we're going to try to do an ejaculation sparing technique because I think it's possible, because he has not a very bulky apex, so I think it's going to be possible. What we see here is that slight hole. Generally, you can use this slight hole right here to see where is the correct plan, because generally it begins here. The plan can begin here, so it can help you a little bit to find the correct plane of enucleation. And then after we check the bladder neck, we see the previous incisions, and we will see during the dissection how we can manage it. And then after, check ureteral orifice, which are very far from the bladder neck, so no problem with that. I won't check it anymore during the surgery. So have you got some scissors? So I will present you the laser. So as I told you yesterday, it's a laser we developed with Quanta System and Rocamed. So it's a 200 watts laser of thulium, the second generation of thulium. Now we have the 2 flap, but it was the second generation of thulium. So the settings are, it's a long pulse, 20 milliseconds, with a low frequency to try to increase the power we have in each pulse during the surgery. And with that, try to optimize the Moses effect we can have in the thulium, which is much lower than the one you have with the holmium. But we have some Moses effect. So it's a 200 watt laser, but if we combine the different settings, it will be 60 watts for each pulse. All right. So every pulse will have 200 watts, but if you combine it during the seconds, it will be 60 watts. So, okay. And so we check the laser and we check the settings to have some ability of the settings to adapt to enucleation, vapoenucleation, or vaporization, which is in continuous mode. What you have to know with the thulium, the more continuous you are, the more charring you are, and the more hemostatic you are. So that's the reason why we have 2 pedals, one for enucleation in pulse mode and one for coagulation in continuous mode, to have an optimization of the hemostasis during cauterization. So we're going to begin. So we're going to try to do an en bloc technique. So as you can see, I begin under the right lobe. You see how hemostatic properties of the thulium are working. So I will check the verimontanum, and I try to not to coagulate it or damage it, and I will try to keep the 1 centimeter of tissue above the verimontanum, because the ejaculatory ducts are running right here. All right. So one of the problem of the surgery of TRP or enucleation, that it's possible here to cut the ejaculatory ducts here, or cut the muscle who supply the ejaculation. So what we're going to do at the beginning is to try to cut all the small fibers from the urethra to the adenoma, So I won't push blunt dissection until I cut all these small fibers. I try to approach a little bit the plan of dissection. And now it's marked. I will mark a little bit the upper part to try not to injure the sphincter. And I try to cut all these supporting tissue of the urethra to try to have more and more mobility of the apex. So slightly, gently, we're going to try to find the plane of enucleation, and it works. So, as I told you yesterday, I try to be the less traumatic, and so that's the reason why I try to reduce the blunt dissection of the prostate, not to tract on the tissue, not to damage the functional structures of anatomy. So you can see that there is an important difference between the pulse of the thulium and the pulse of the holmium. And you see the difference of Moses effect, but the difference of hemostatic effect too. So I think the adenoma is here. So I will try to disconnect it properly. So sometimes right lobe is easier, sometimes left lobe is easier. So if it's difficult on a right lobe, I will switch to the left. So I will try to see the volume of the adenoma. I will cut this small attachment from the sphincter to the adenoma. And you see, I will try to go very carefully. What I try to find is the correct plane, because if I have it, it will be possible to reach the top of the adenoma and detach the sphincter properly. So I try to turn a little bit my endoscope during the dissection to fit the volume of the prostate. So I will have more and more space, I hope, during the dissection. So what I will try to see now is the attachment of the sphincter and the arch of the sphincter on the adenoma. So I go carefully. It's, of course, the most difficult part of the surgery. It's the apex detachment. So my wings are quite useful to expose the plan. of dissection. So here it's very interesting. It's something I changed perhaps a few months ago, perhaps 1 or 2 years ago. What you have to see is capital. Here you have the adenoma, all right? And actually here you have the capsule. And during the exposition, you see, I tracked a little bit on the capsule, all right? So before I was working over there. Now, sorry. Now I'm working right here. You see the difference? Because when you expose your adenoma, you have to understand that you tracked a little bit the capsule. And if you track the capsule, it changes a little bit the plane. And if you shoot in the capsule, you're going to have some small damages of the capsule that make bleed and that make, I think, irritative symptom in the postoperative follow-up. So it's a real surgery. So there is exposition, there is traction on the structures, and you have to see that and apply that to the way you manage the shoot of the sphincter. So very important here to be close to the adenoma and detach the structure properly without any traumatism of the sphincter. I have to be quite concentrated right now. Okay. So as you can see, it's not exactly the same plan of holmium. I do holmium too. I'm working in 2 institutions, so one with the thulium, one with the Lumenis 100 watts. And I have to admit that it's not exactly the same plane of dissection. I think that you have to be closer to the adenoma during the thulium because it's very easy to disrupt the capsule during the dissection. Because as Fernando told you, it's a device to cut very well. So it's totally possible to do bladder tumors with that, to do upper urinary tract tumors with that, with an amazing result. And so it's a laser who cut and destroy a little bit. So you have to be very, very careful with that. And try to be very close to the adenoma to avoid any traumatism of the surgical capsule. Okay, so it's not so bad. So I will finish the detachment of the apex.
Could we have the microphone for Professor Gomez-Sampson?
Yeah. So now we are at the anterior part of the prostate. We can go properly with a quite good vision. And that's what is interesting with the thulium too. Because of the properties of hemostasis, it's quite easy to have a very good view during the dissection. Okay, so I will check the apex. So we will see here the attachment of the sphincter on the adenoma. So I will prefer to be close to the adenoma at this part, preserving the sphincter perfectly well. So as you can see here, I detach it slowly and properly. It's definitely the most difficult part of the surgery. Okay. Okay, now it's detached. So I will do a non-block technique. So now we're going to preserve the verimontanum and the cismontanal urethra, as you can see, to try to spare ejaculatory ducts.
So, Jean-Baptiste, what is your success rate when you try to preserve ejaculation?
So, to be honest, there are plenty of techniques. What we know is that if I'm doing this, if I spare the upper part of the verimontanum, I will spare ejaculation for perhaps 50%, all right? What we can do after is to change a little bit the dissection, not to take the anatomical plan, but mark right here the adenoma and cut the anterior groove. And when I'm coming to the apex, just let all that stuff, all right? So if I let this, the apex, and I let this, I will be more than 75% of keeping antegrade ejaculation. But if you do that, you're going to have an obstruction at the apex. So your voiding result, I think, going to decrease. So that's the reason why it's quite difficult to be very sure that your results between the adenoma and the voiding result and the ejaculation result will be good. And so what I'm doing when I have a patient who want to keep his ejaculation, generally it's a young patient, all right? So generally the prostate is not so big. So when the prostate is quite mild or small, it's quite easy to perform this kind of technique. And I perform a fibroscopy before to see the shape of the apex. If there is an obstructive apex, I say to the patient, it's not possible to guarantee an ejaculation sparing with a good voiding result. So, but it works, huh? If you take the apex, if you keep the apex and you keep the verimontanum and the cismontanal region, you're gonna keep ejaculation plenty of times. So it's important to cut, as I told you, all the supporting tissue around the apex before mobilize it with the endoscope, not to be traumatic. The plan is a little bit.
We can see that the quality of hemostasis is outstanding, but at the same time, it's easy to see that the effect of dissection of the plane is not as it was.
Yeah, it's a little bit. It's more difficult with the thulium for sure, because the mechanical effect of the bubble, you don't have it. So
what is the expected PSA in your patients? What do you expect the PSA to be post-op?
The PSA drop,
yes,
honestly, is really good, more than 80%. I think there is no big difference between holmium laser and thulium laser on this. If you do a real anatomic dissection of the plan, you're going to have the same result for the PSA drop. And it's very interesting. Enucleation for that is very interesting, because if you want to be sure that there is, if you have a PSA more than 2 nanogram per milliliter after this surgery, you can be almost sure that there is a prostate cancer after the enucleation, because generally the PSA drop is very important after enucleation. And what I have to say too, which is very interesting with all the enucleation technique, is that you are sure of your voiding results. So if you have some problems with voiding problems after the surgery, you can be sure that there is no residual obstruction. and you can manage an overactive bladder or something. So I will do a little bit of mechanical dissection because it's not opening well with the laser. So I've got a small module right here.
In the cases that you don't have a good plan, is it preferable to continue the operation in an even not optimal plane, or you have to insist to find the correct plane?
Excuse me, I didn't understand the question.
When you don't have a good plane, what do you prefer to do?
Yeah, I understand. Okay, yes, it's important to keep the good plan, but sometimes if you have a landmark between two planes, it's possible to cut a little bit in the adenoma. But generally, yes, if you can keep the good plan, it's better to have it, of course, because you're going to remove all the prostatic adenomatous tissue with that technique. Yes, of course, I would try to have the good plan, but as I told you, it's not always very easy with the thulium. I think it's anatomical enucleation, but the plane is not as always the same that you have in the thulium. With the holmium, sorry. I think that the choroid plane is right here. I have to be a little bit concentrated for detachments of the sphincter.
The problem of thulium lasers has been that surgeons who use them where there's a lot of papers of enucleation that are very difficult to interpret, and degrees of removal of BPH. So do an anatomically guided, when you use these pushes to find that you are in the right plane to do an anatomical enucleation, then it's more similar to HOLEP in the sense that you try to do a proper anatomical, and this is the difference between THUVEP and THULEP, that intentionality to go all the way to the proper plane. The thulium pulse, thulium can do an anatomical job, a perfect job, a lot of experience.
Okay, I will cut the urethra at the top of the apex and try to reach the right plane of dissection. Water, okay, it's okay. Okay, so
if I can add a small remark comparing holmium with thulium, is that the holmium preserve the quality, the visual quality of the tissue, so it's much more easier to follow the correct plane once you're found it. In this case, the charring that is secondary to the action of thulium laser transform the enucleation as Fernando has already said, in an inventing plane. I think you are supposed to go on the right plane, but the anatomical reference that you maintain with holmium laser are now more present here.
So, is there any experience in the results if you don't have the correct plane and you just invent it? Do you have different results?
Basically, when you perform enucleation, sometimes you are compelled to invent the plane because, for instance, there could be inflammatory processes, previous prostatic biopsies that can distort the plane. But it's just a matter, as Fernando said, of experience. You go on the according to your experience where the plane is supposed to be. But for a beginner, it could be very difficult and very disorienting, very not so easy to follow.
All the bulking techniques have the potential to improve, and we have seen that for resections, excellent results, functional results at the beginning. The problem with leaving change, the prostate will collapse, and then remaining BPH tissue will grow. So, what we doing a channel in the center of the prostate, patients would have extremely good flows. It was very minimally invasive. We didn't leave a catheter, but of course, with time, this didn't last too much. So I think when you invent a plane, the patient will do well, but similarly to a TURP, in the sense that you debulked the center of the prostate.
1200, puis je monte
And
jusqu'à...
functionally, they will do well, but it won't last over time, I think.
So I think we do a good job now. As you can see, probably the anatomical plan is not exactly the same that the one we have in Olmium, but I think it's quite good. As you can see, there is no damage of the capsule. Of course, you always have some small nodules who makes hernia in the capsule, which are very, very difficult to release. And generally, I have to say that if they are small, I won't remove them. And it's, of course, probably a risk of recurrence, but it's quite small. As you can see, we will remove, I think, more than 90% of the adenoma, even with the thulium.
The surgeon must have the heart of the lion, the eyes of the hawk, and the hands of the lady. And you have ladies' hands, You're very, very careful and very, very gentle, and that's very beautiful. I think you have the breath of the lion more than after yesterday.
So now we're gonna try to dissect the anterior part and find the bladder neck properly. So it's with the thulium, it's possible not to touch. So if you are not touching the tissue, right, you're gonna have a site of dissection. But if you go in the tissue like this, you're gonna cut. So you have to manage the distance of your tip of the fiber during all the surgery. And sometimes you have to be very close to the tissue, and sometimes you have to be far, just not to perforate or to go too deep with the laser. So this is the anterolateral part.
Impression
This is the plan on the right.
is that the thulium laser and the thulium fiber laser have even better hemostasis than holmium, even with Moses. But of course, they have the disadvantage of not opening up the plane so much.
Yeah.
What do you think it's to learn? I mean, would you learn with a holmium, or can you safely learn with a thulium laser? What do you advise people?
Yeah, I think probably if you begin with enucleation first, holmium will be easier. I think that. But I think that if you use first vaporization of the prostate, TUVEP, and after TULEP, it will be definitely possible. Because if you have a problem during your TULEP, it will be possible to switch to a TUVEP, and you will finish your procedure without any big problem with your patient. So I think it's possible to begin with a TULEP. It's probably for the dissection technique a little bit more difficult, but I think that it's the same with the green lab. The green lab is a continuous wave, a continuous emission, and during a continuous emission, you have no help to open the plant. But what you have to know is that in Saint-Augustin, we do OLEP, and we coagulate all the patients after the surgery. So generally, we don't do like Fernando, coagulation with the holmium. We generally coagulate with the electric ball, and it's not the case with the thulium. So perhaps with the next generation, or the Moses 2.0, or the virtual basket, the results of coagulation for the holmium are better. But it was not the case with our Lumenis 100 watt, and it's a problem. It's an intellectual problem, I think, to have to change energy to make the coagulation, to make the patient be discharged at day 1, because generally before coagulation, our patient with holmium were discharged at day 2 or day 3, and that's an issue. And with the thulium, I can say never, but I almost never use the coagulation of the electrocautery after the surgery. And I think that with that, we reduce the irritative problems. And so it's an interesting technique for that, an interesting length weight. And what you have to know too, that even if it's probably a little bit more difficult to do the enucleation at the beginning, you can do plenty of things with the thulium. You can treat your bladder tumors, you can treat your upper urinary tract tumors, you can open the stenosis very well. So I think it's really difficult now in an operative theater not to have a thulium inside your theater, because it's very, very useful for a lot of things. And that's an issue.
How good is this laser for stones?
What?
How good for stones?
Yeah, you can do the stone with it. So, for example, if you have a 2 flap, you will be a little bit more difficult than the holmium to do the enucleation of prostate, but you will do plenty of things with that. And believe me, for stone, it's amazing. For incision, for upper urinary tract, it's amazing. I almost do all my low-grade tumor of upper urinary tract with the thulium now. No more nephroureterectomy or robotic surgery for this guy, with excellent results. And for bladder tumor, it's possible to do 1-day surgery with that. So it's definitely quite interesting.
Just a question. Suppose that I'm a very rich surgeon and that I'm going to buy a new laser, and I'm very interested in thulium. What do you suggest? A standard thulium laser or the so-called super thulium laser?
No, I'm probably going to buy a super thulium, because with that, you're going to do stones very nicely. Because
do you
stones,
think it's as effective as a standard thulium?
Super thulium with stones, it's incredible. It's incredible because there is no residual stones after the surgery. So that's the big issue with the holmium. You always have residual fragments on the CT scan, and it will be not the case if you do it with a super thulium. So for flexible rhinoscopy, it's a great advantage. So I will try to develop a little bit more the posterior plan. What I have to check, yes?
Jean-Baptiste, and what about the strictures after the procedure? Do you see any difference in the strictures rate between the different energy sources? It's about the size of the scope. It's about the time of the procedure. It's about the blunt dissection and the movements you do in the urethra. So how does this affect the strictures rate after the procedure?
About urethral strictures? Urethral strictures?
Yes, urethral strictures
Yeah.
after the procedure.
To be honest, I think that it's not problem of the laser or time of enucleation. I think it's a problem with the resectoscope. That's a problem of the sheath of the resectoscope. So I think that for Wolf, you have to use 24. For Storz, the resectoscope is very smooth. So there is no problem with urethral stricture generally. So of course, as for this patient, you have to do an urethrotomy if your urethra is too narrow to avoid any ischemia during the surgery. But generally, it was a problem at the beginning because we were working with the Wolf 26 resectoscope. We had a lot of strictures. Now we don't have anymore. So it's not a big issue. And I don't think it's a question of the laser. It's a question of the resectoscope. But now the industry have worked on that. And I think that with Wolf or with Storz now we have pretty good results about that. So I will do a proper incision of the lateral plane to try to find the correct posterior plane. I think that I had difficulties at the beginning because I tried to find the posterior plane of the adenoma from the apex. And I don't think it's a good way to reach it because you have 2 or 3 planes there, and it's very, very easy to be in the wrong plane. So now I try to find the plane from the lateral approach. So I cut and I develop a lot this plane. And with this, generally, when I convert and when I switch to the posterior plane, I have the right one. So as Fernando told you, it's very important to curve during your dissection. So you adapt the laser. You see, as you can see here, there is fatty tissue. So I have to be closer to the adenoma. Again, it's really easy to go outside. It's not a big issue for post-operative follow-up and results, but you have to be careful during your dissection with that. As you can see, it's a laser concata. You have to accept that it's difficult to have exactly the same aspect during thulium dissection and holmium dissection. It's like that. But the results have been published and they are quite good. And to be honest, it's a feeling I have.
Have you any complaints about sexual dysfunction after with the use of thulium?
So exposure needs to be very good at this part because at the posterior plane, generally the capsule is very thin because the prostatic adenoma pull on the capsule and makes it very, very thin at this part. So we have to be very careful with that if we want to avoid bleeding, because generally bleeding is coming from mucosa or disrupture in the capsule.
Jean-Baptiste?
Yeah.
Do you hear me? Do you have any complaints about sexual dysfunction when you use thulium?
I'm sorry.
Do you have complaints about
Erectile
sexual
function problems? No.
erectile dysfunction?
No, we don't have that, honestly. I have to say to the patient that psychologically it's possible to have a problem with erectile function, but generally in the holmium or with the thulium, the leg wakes and the deliverance of the energy to the tissue is very superficial, so it's not an issue. It's you have to know that it's just 0.2 millimeters the energy. That's all. So let's see if it's possible to switch a little bit the adenoma. It's not so bad. No, erectile function is definitely not the issue. The issue is the ejaculation. And I think that's going to be interesting to compare the technique of ejaculation sparing and aquablation, rhythm. And I think that the real challenge for laser will be that new techniques who can give you a proper result with a good disobstruction, keeping the ejaculation. The real challenger will be probably rhythm or aquabeam therapy or aquablation. Okay. So it's done. Probably we have a small nodule right here. So it's possible to vaporize it a little bit. Okay, we're going to do the hemostasis. So as you can see, there is not a lot of adenoma inside the patient anymore, even if the plan is a little bit different. So I will reduce the flow of the irrigation to see what is bleeding. But generally with the thulium, there is not a lot of additional coagulation that you need after your enucleation. And as you can say, as I told you, it's very it's exceptional that I need to take the electrocautery after the surgery, as I do in holmium surgery. So this is continuous wave, continuous emission, sorry. So it's like this that we have the best hemostatic effect. And I think it's a real problem at the moment, because I think that I try to have the proper equipment in St. Augustine, and it's difficult to buy different laser. But I can say that it's going to be mandatory to have a thulium laser in your operative theater. I know it's difficult, I know it's very expensive, but how useful it is, it's incredible.
So, do you believe that in an ideal world you will do the enucleation with HOLEP, and after that we will change to thulium for the hemostasis?
Une fois qu'on va faire l'énucléation à l'holmium, on va changer au thulium pour hémostase.
It could be an idea. It could be an idea. I think that at the moment there is no perfect laser on the market. What I can say is that, to be perfectly honest, it's not difficult to do an enucleation of prostate with the thulium if it's not too big. If you have a prostate till 140 grams, it's okay. Above, to be honest, I prefer holmium because the ability of enucleation is probably a little bit better. But if you want to do to 100 grams or 120 grams, thulium is working well with excellent results. But you know, when I operate thulium, generally it's Friday, and I'm always very confident in the fact that the patient will be discharged the day after. For holmium, it's not always the case. Okay, so we reduce the flow again, because it's very important for you to begin your morcellation in very good condition of vision. And it's mandatory to come back and do the coagulation before the morcellation if you don't have a proper vision. Okay, so we're gonna go to morcellation. Thank you. It's okay.
So which morcellator are you going to use?
So morcellator is a Stotz morcellator. I like it because it's very solid. We had some problem with the valve system in St. Augustine because you have to know that we are plenty of surgeons, and it was so fragile that after 1 month everything was broken. And because you have to know that we had beginners for enucleation, we have people who were working with Stotz before, we had plenty of surgeons inside we are 9 surgeons, so we have a lot of different surgeons, and it was too fragile, and we had a problem because all our device for laparoscopy and cystoscopy were Stotz, and it's not possible to adapt the Stotz optic on the valve device. So we had one valve device, and when the optic was broken, or just after, it was all the enucleation technique was blocked for perhaps 2 months, and that's the reason why we decided to switch to Stotz. So Stotz is quite solid. We have not a lot of problem with that. Probably it works a little bit slower, but to lose 2 minutes or 4 minutes, can you go up to 1,800? And to lose perhaps 10 minutes or 5 minutes, but to be sure that you're going to have some proper possibilities to do all your enucleation during the week for you and your partners. It's quite interesting. As I told to Andrea, I think it's very interesting to have a look on the Neptune system, which is a striker system. It's not for the surgeons, it's for the nurse. And we have this in St. Augustin now for probably 2 months, and it works very well. It's going to take all the fluid of the suction during the enucleation and manage it. So it has its own pump to suck the liquid, and it's totally possible to make more than 100 liters inside, and so you never stop during your morcellation. You should have a look on that. It's very interesting for the nurse. So always I try to go inside the prostate fossa to do the morcellation, to block the adenoma during the morcellation. Here it's not very hard adenoma, so it's not a big issue. So we have here very non-tenon, 1 centimeter above, to try to keep ejaculation. I will check the bladder to be sure that there is nothing inside. Okay. Check the clots we can have inside the prostatic fossa. I think perhaps there is something here. So we'll cut the irrigation, use only the pedal for suction. And that's all.
Your comment with the use of these tools. In my experience, I had many accidents with the oscillator, more than I should, but I never had any serious complication for the patient with that. So it's important to be careful, but is it a tool that should be the new urologist afraid of? What do you think? Your comment, please.
What is interesting with at the moment with the thulium is all the papers going out and published.
I was
You
asking
see that
if the accidents that happens during the oscillation are serious complications for the patient or not, usually.
so as you can see, I don't know if you, yeah. Comment je manage ça? It's okay. So as you can see, it's crystal clear, and it's usually like that. So accident with the morcellation, I think that you're going to have accident with the morcellation if you have not a good condition of vision during your morcellation, first. And second, if your nurse or all the staff are not well trained to do this. One of the problem could be that the water stopped because the nurse didn't change the bags of water properly. The accident can happen if you have bad quality of vision and take the bladder wall. To be honest, we had some small perforation and a small lesion of the mucosa during the initial part of our activity. The initial part of our activity. But now I think it's okay because we have pump, we have the Neptune system, we have a pump of suction, the black one that we have here. It's the Storz pump who can suck very properly the liquid to have a good aspiration. And if you have a good aspiration, you have a good suction, you're going to have all the time the adenoma block in the mouth of the morcellator, and so you suck just a little bit of liquid. And we have we were working with a Storz pump too to water income. So we are always on pressure. It's possible to have a roller pump. You can generally I set it to 50 millimeters of water, and with that I'm sure that I have always the good pressure and the good inflation of the bladder during the morcellation. And for the injuries, the only we had was some small mucosa injuries, which is a problem because it bleed a little bit and need a proper electrocoagulation after. But to be honest, it's not a big issue if you are well trained, if your nurse are well trained, and if you have the proper device.
So you never had a major complication with the morcellation? A complication that caused the patient to stay more days in the hospital or something like that?
With the bladder injury during the morcellation? No, generally not. If you coagulate properly your bladder,
it's not a problem. Of course, if you have done a big hole in the bladder wall, it's going to be a problem. But for me, it's not normal to have that kind of complication. It's possible to take a little bit the mucosa with a big prostate when it's bleed a little bit. But if you have a big injury of your bladder wall, the reason is that your coagulation of your prostatic fossa is not correct. And if the coagulation is not correct, you don't have to begin your morcellation. You have to stop. You have to take back your electrocautery or your laser and be sure that when you reduce the intake, the income of the water, there is no important bleeding that makes that your vision is not clear. You have to understand that when you do the morcellation, you reduce the water income of 70%. So you have only 30% of your irrigation fluid during the morcellation. And that's the reason why you need to see better you have to see better at the end of your enucleation that it was during your enucleation that it was during the enucleation, because of the reduction of this irrigation. So be very careful at the end of the surgery to do a proper coagulation, and with that, I think that you're going to avoid any complication with the morcellation. And of course, you have to take your nurse and go to an expat center to see how these things works, or perhaps work with the industry to tell people how it works, and have the proper device of water income and water outcome.
So, Jean-Baptiste, some questions. First of all, when are you going to remove the catheter from this patient? One. And what kind of instructions are you going to give to him?
As you can see,
what he has to expect the first weeks in terms of symptoms.
So, probably, as you can see, with the thulium, it's hemostasis. It is generally not a problem. So you can remove the catheter, I think, the day after without any problem. Okay. What I expect, it's generally that the result is pretty good. That irritative symptom is less than 5%. Stress urinary incontinence is less than 2%. And generally, if you have irritative symptom, these irritative symptoms are going to come for 3 weeks, because the cicatrization of the prostatic fossa go very fast because of the physical characteristic of the laser. So generally, more than 80% of my patients are discharged the day after. I have to be honest, I think that, for example, for this patient, it will be possible to be discharged this afternoon. So it depends a lot of things. When you discharge a patient the day after, you are sure that during the night you won't have a small clot or something, or pain or something that the patient is going to call you first. Second, you need to have at home, you need to have a specific urological nurse at home, because remove a bladder catheter after an enucleation, it's not very, it's quite specific. The way I use it, generally the nurse is going to deflate the balloon. Then she tracked a little bit the bladder catheter. She washed the prostatic fossa, remove all the clots. And then after, she put 200 milliliters of liquid inside the bladder of the patient. And like that, he will void immediately. And to have a nurse who can do this at home, it's quite difficult. We don't have that in France. There's that kind of specific free nurse downtown. And so that's the reason why I keep the patient one night. And to be honest, we don't have any emergency unit in Saint Augustine. So if you have 3 or 4 enucleation a day and they call you all the nights along with the schedule of the program of the surgical activities the day after, it's not possible. So that's the reason why we keep them one night. And generally, I don't see the patient before 3 months. I see them if they have a problem. But generally, I ask a PSA. I ask for ultrasonography. Generally, 3 months after and check if there is any problem. And if the patient is not comfortable after the enucleation, he can call me, of course, 1 week or 2 weeks after. But so that's generally how it works. And so it's of course, enucleation for this is very comfortable because you discharge the patient the day after and you reduce the occupation of your clinic. And so like this, you can reduce the number of nurses, reduce the number of beds. I think I will never switch back to TRP because in my activity, it changed a lot of things for me and for the department when we began that. At the beginning at St. Augustine, I was the only surgeon who was doing enucleation, and now we are 6. So almost all the procedures now for BPH are done by laser enucleation, thulium or holmium. I think that all that thing, all that stuff, we see how we come from where we come from. It was more or less 10 years ago we began the enucleation after Fernando in Bulgaria, and it changed a lot our practice. But what changed a lot is the material, the stuff. At the beginning, there were no resectoscope, no pump, no proper laser. It was really difficult to begin this activity. But I think that industry will be there more and more. And with the time, thulium, holmium, green light, we're going to find, I think, the best laser to do it properly. It's important to work on that with the experts. But for the beginners, what is important is to learn the good technique. How you have to manage your resectoscope, how you have to manage your apex, how you have to manage your morcellation. I think don't forget that the medical device, it's important, but the surgical technique, I think, is the most important thing that you have to learn. And after, with the experts, with the industry, you're going to have proper stuff. I see what it was 10 years ago, and I see what it is now. Everything has changed. So it's going to be more and more effective with the time.
Just for the organization, we're really in advance, so this is very it's fine. We will profit for the next hour if you have questions, and we will discuss at the room upstairs. Profit to ask questions to Dr. Gomez Sancha, because we will dismiss him in the afternoon, and we're coming with Jean-Baptiste in 2 minutes at the conference room, and we will start the third operation at 1 o'clock and not 2 o'clock, because we are really in advance. Okay, see you upstairs.
So thank you very much, and a big applause from us. Thank you. So we have 5 minutes for a break, or yes, yeah.